Episode 10, Learning Proper Movement Patterns and Treatment Techniques for Low Back Pain from Airrosti rehab provider, Dr. Justin Bryant. Welcome back, everyone. Thank you so much for joining me on what I know will be another amazing episode. I am your host, Chase Tuning, and this is EverForward Radio. I am here with a friend, colleague, coworker, and all-around somewhat decent human being, Dr. Justin Bryant. Dr. JB, why don't you give a little intro of yourself, please?
Hey, guys. As Chase said, Dr. Justin Bryant, I am a chiropractor by trade, is what my degree says. But as we will get into it today, not really treat the way a traditional chiro treats, I would say. Would you agree with that?
Yeah. So how do you treat? When you say treatment, what is your practice? What is your modality?
So really my approach, I work for a large company. We're called Airrosti Rehab Centers. It's AIRROSTI.
And that's Spanish for the Airrosti, right?
San Diego.
Nice. I was way off.
But
it means something. What does it mean?
So actually, it's a huge long acronym. It stands for the Applied Integration of the Rapid Recovery of Soft Tissue Injuries.
Nice, you passed.
Yep, it's quite the mouthful. But I use that sometimes to describe what we do. And the first part is I kind of talk about the rapid recovery. Mm-hmm. On average, we've got about 180 chiros and PTs on staff across the country. And our national average is about 3.2 visits to like completely resolve an injury, whether it's acute, whether it's chronic, whether it's in your shoulder, whether it's in your low back, whatever the case is. And the soft tissue injury is what I'll kind of dive into now is when I see a patient and they come into my office to get treated, I spend an hour with them. Mm-hmm. The first 30 minutes is very extensive sort of history exam, functional exam, how are they moving, how are they not moving.
Kind of like a screening assessment.
Somewhat, yeah. And then really sort of intense, deep manual therapy, really focusing on the fascial component of our musculoskeletal system. And then 30 minutes of rehab, like physical therapy.
So why would someone come to see you over a physical therapist? Traditional DPT or just PT?
It really depends, and even for chiros too, right? There are some really great chiros and PTs out there that do a really good job. And there are some chiros and PTs out there that are more financially driven and less patient driven. So going to like a traditional PT or a chiro, there may not be any manual therapy involved whatsoever. That may all be passive modalities. Just I'm going to put some stim on you. You're going to do these stretches.
Speaking from experience, it definitely, I've been through my fair share of physical therapy, and that rings true because you go for a particular incident. For me, it was a significant injury / surgery recovery. And then they kind of go through some, like, mostly like assisted stretching, and then like, hey, here's your homework, here are your stretches and stuff to do on your own. So that's kind of what traditional PT looks like. Yeah. And insert Airrosti.
Right. So like traditional PT chiro can last a long time.
Yeah, months.
And if you add up all those co-pays, it starts to cost a lot of money, a lot of time out of your life where you just got to go into that office 2 or 3 times a week. And then resolution rate or whether things actually get better or not are just all over the board. Sometimes it goes away. And I'm the amateur, Chase. I remember the first podcast that I ever did.
I don't know how to turn off these notifications.
So you may go to a traditional PT or traditional chiro that can take a long time. They have a long treatment plan drawn out for you. And sometimes it doesn't even correct things. Like it's kind of hit or miss whether it goes away or not. What I do and what my company does is we really focus on truly treating the site of pain, but also when we do our rehab, it's trying to fix what caused the pain in the first place.
So the root, not just like treating symptoms.
Right. So we're not just treating the symptoms. We're trying to find why is this person having symptoms. Most of the time it's like a faulty movement pattern, and we'll kind of get into that in a little bit. Yeah. But really the big stressor is we can take the pain away and we can increase range of motion, and that's what I do my first half, right?
Yeah.
When I'm doing the manual therapy, I'm helping decrease pain and increase range of motion. And then when we go into the rehab room, treating the root cause of it.
Right.
But the biggest thing for me is my patients are being educated on how to take care of this long term. So I tell all my patients, like, you're going to walk out of here in 3 days, you're going to be feeling super awesome. Continue with your rehab exercises. What will happen is, let's just say it's low back pain.
Sure.
They'll be feeling totally normal. You'll naturally kind of just fall off on your rehab. That's cool. It's fine. It's going to happen.
Like, as far as like adherence to what we're supposed to be doing at home.
And then let's say 3 years from now you're in the gym and you do a back squat or a deadlift or something, and all of a sudden that low back pain zings you real quick.
Yeah.
What I tell my patients to do is open up your rehab again, and I want you to go through that rehab religiously for like a week. If the low back pain doesn't go away, then give me a call.
Okay.
But a large amount of time, if something tightens up or flares up on a patient, and they just open up their rehab and start doing it religiously again, it calms down on their own. So really trying to make the patient, I guess the difference is that we have proven results, we get the results quickly, and we educate patients on how to take care of it long term. I think that's what you need to find in a good physio, someone who
makes sense.
is going to take care of you fast and teach you how to take care of it long term. So you as the patient are independent of doctors. Right? Doctors, I think, at our core really are like teachers. We should teach someone how to rehab or move properly. That's kind of my arena. But say like an internal medicine doc or a primary care, they should not just treat your symptoms, but they should teach you, much like you do, Chase, teach you about the benefits of a healthy diet. Supplements that you can take to help with certain things, like a natural approach to it too.
How what you're doing can directly affect your success or your barriers, really. It's
not just like, all right, Mr. Smith, you've got high blood pressure, here's this high blood pressure med, and come back and see me in 6 months. Whereas instead, as a doctor should say, okay, you've got high blood pressure med, let's put you on this med for a 4-week span to just get the levels down to normal. In those 4 weeks, let's work on getting more steps in through your day, starting to exercise, starting to eat healthy, so that you can treat it on your own. And then you can get off the meds and be good to go. So I think that's the big difference between me and traditional PT is that I get patients better really quick. And I educate them on how to take care of it long term.
So who would be someone coming in to see you? Someone who, like, do I have to wait until I hurt myself to see you? Like, what is kind of like the common denominator in your patient type?
I would say, so I see a lot of athletes in my clinic, and not that that's my focus, but I think that because I grew up as an athlete, it may not show. I have what's popularly called a dad bod.
If Leo can pull it off, we can.
And supposedly dad bods are in. So I just kind of have somehow surrounded myself by athletes. But really anybody that, if you're having some sort of ache or pain that is not going away, let's say that like you go on YouTube and you look up some stuff to do with a foam roller or lacrosse ball, maybe some rehab
Which
stuff.
is really big. I mean, anybody can go online and find a mobility, some TheraBand, some lacrosse ball stuff.
Yeah, absolutely. There's a lot of resources out there that people can try to tap into, but the problem is it's not specialized to your case, but it may help a lot. So I think that a person should seek out a physio when they have tried to do some stuff on their own, maybe modified their lifts in the gym, and it's still bothering them. Or they try to go back to their normal lift or their normal daily activities, and it just immediately flares back up again.
Kind of having the recurring problem.
Yeah, it's not going away. It's like, I've tried this and this and this. You really should go to a good physio first. If that doesn't clear up, then the option would be, okay, let's go talk to an ortho, or let's go talk to someone who specializes in like PRP injections, and do a little more invasive stuff. But really, if it's just...
Save that for like worst case scenario.
What should happen in a perfect world is those aches and pains should be treated conservatively first. Mm-hmm. And if conservative treatment doesn't work, mm-hmm. then you look at injections. And that can be, like I said, steroid injections, PRP injections.
Yeah, sure. I'm sure the majority of people who are in this audience are people who are active,
right?
Athletes, weekend warriors. We have a lot of aches and pains.
Yeah.
We probably don't really pay attention to them as often or give them as much significance as maybe we should. So, for example, like me, I get a lot of low back tightness mm-hmm. when I'm doing heavy squats or heavy deadlifts. Mm-hmm. And, I feel like I have pretty good form and technique, but, nobody's perfect.
Yeah.
Those are two really technical movements and take years to really perfect. Yeah. So, I don't have what I would say like an injury right now. Say I'm a patient mm-hmm. coming in, but I just have like some low back tightness and maybe getting some like anterior tilt or something going on that is just lingering longer than it should be that I know is not just normal muscle soreness. So I'm coming in with that scenario. What what would you do? How would you address that?
If it was just kind of just like I've got some low back stiffness, but it's only coming on when I'm really pressing like what my PR is on
sure.
a deadlift or back squat. I think that's gonna be more of a let's look at how you're moving. Mm-hmm. Are your hips moving? Like,
what would you do first? I walk in, like you would actually have me go through the motion?
Yeah, basically what I would do is get your history. Obviously, what's mm-hmm. going on? When is it bothering you? When did it start? Where do you feel it? Is it down the leg? Is it stuff like that, right? Yeah. And then I'm gonna move into some movement screens. So mm-hmm. let me see your squat. And watch you squat. Mm-hmm. And unfortunately, I'm not in a gym, so I can't put you on a bar.
Not like load bearing. This is just all body weight.
Right.
Okay.
So I'm gonna have you squat. I'm gonna have you do some lunges. I'm gonna have kind of see what your deadlift setup is. Mm-hmm. See how and if it's low back related, I'm gonna be kind of zeroed in on your lumbar spine mm-hmm. and that sort of hip pelvic complex.
Okay.
Watch how they move up and down through your squat and your deadlift. See if I see some movement patterns that I don't like. And then based on that will tell me, like, okay, I'm seeing this person, they've got what's called a butt wink.
Yeah. When you get down the booty pop, when you go down real low, like in the squat predominantly, and pretty much after you break parallel, you go, we all want to think, ass to grass, basically. So that isn't always a good thing, though, right?
Yeah, and just for anybody's reference out there, do not mention a butt wink unless you know that the person knows what you're talking about.
You might get yourself into some different territory.
I did. I had a patient that I mentioned that, thinking that she would understand what I was saying. Yeah. And she had never heard that before. And you can imagine I had to backpedal pretty quickly.
See what had happened.
The common term butt wink, right? And it's when you're dropping down into your squat and you see those hips essentially like tuck under you.
Sure.
Right? And so that's telling me that there's certain muscles that are tight. Mm-hmm. It can be hamstrings, it can be adductors, it can be hip flexors, and I'm gonna...
Because everything's integrated right there with a squat. It's head to toe pretty much. And it's all centralized in that common crossing point of the hips, the gait, the low back, everything. Yeah.
I mean, and look at our ancestors, right? They could drop down into a beautiful squat
and hold it.
Look at a 1-year-old who's just learning how to walk, and they squat down. It is the most beautiful squat you'll ever see. It is so functionally sound.
Yeah, but I'm pretty sure my squat PR is more than a 1-year-old, so...
But they don't have low back tightness and stiffness like you do.
Touche.
But what happened is we evolved from people who would sit around a campfire, and when they sat, they would sit into a deep squat.
Yeah.
Or they'd sit on the ground, which is totally different than sitting in a chair.
Yeah.
So chairs have just been around recently, and we sit in this position all the time.
Yep.
It increases the pressure in our discs. It tightens up our hips.
Sitting is what's been called the new smoking, because we go through all this hard work. Maybe you go to an early morning workout session, you go to work, you drive to work, you sit.
Yeah.
You go to work, you sit, and 7, 8, 10 hours. That 8 hours can offset. I was reading a study recently of about a 40-minute workout can basically be completely metabolically undone by 8 to 10 hours of sitting.
I feel like I may have gotten off on a tangent. You're going to have to do... I will do this from time to time, is that...
It's going to happen.
I will run off on a tangent. I want you to snap your fingers like a dog and be like, hey, back.
Focus.
I like where you're going with the sitting thing, and we could totally go on that.
Getting back into the assessment with the squat screen.
You would take a patient, you're going to watch... I'm going to watch them from the side and kind of look for certain things. I'm going to look for that pelvic tilt. I'm going to look to see if their torso really leans forward. I'm going to watch and see how low they can get. And then I'm going to look at them from the front, because there's different things you can look for.
So assessing on all planes.
Yeah, you're going to look at on the side, on the front. I'll even look at from the back to kind of see. Some people will do what's called like a lateral shift. So they will almost like load up on one side to get up and out of the squat, and that's will usually, flag my brain to say there's probably a weakness in the glutes on that opposite side, because they're getting away from it because it's not activating, it's not firing. What happens when we sit all day long? Our glutes turn off.
Yeah.
Right? Yeah. Our hip flexors, our quads, they all get tight and overactive. So
they're having to work unnecessarily.
So yeah, I'm gonna run the patient through. I would run you through a squat, and I've looked at your squat before.
Yeah. Which is fairly good.
Fairly good. Chase has a major butt wink. Again, that's clinical term.
Clinical, yes. Clinical butt wink. It's boring really, but it's science. It's part of my life.
At more past parallel on you. So
when I get to parallel and I go deeper in our assessment, I get that butt wink. Okay.
And like literally, we could have a whole episode on just squatting mechanics.
Oh, I'm sure.
So detailed, but
so why do we get that? Why do people have that butt wink?
It's gonna be so. A lot of people will say tight, like posterior chain hamstrings, and I can totally see where that's coming. Right.
I would agree.
Hamstrings attach on kind of the bottom of that iliac bone, and if they're tight, it's gonna pull that iliac bone.
Okay.
But mechanically, if you think about it biomechanically, as you drop down into that position, I actually think that your adductors have an easier path to pull on that hip forward.
And your adductors are...
Sorry, yes. Yeah. So you've got three large muscles that are on the inside of your thigh and attached to what's called like your pubic bone. It's kind of the front of your pelvic sort of cage. Let's call it pelvic cage.
I like it.
Trademark. That's a Dr. J special.
Write that down.
And I think that those adductors have a great ability to pull that hip underneath you, right, when you're dropping down into your squat.
That.
So yeah, it's typically going to be hamstring tightness, adductor tightness, hip flexor tightness, probably too a little bit. That'll kind of pull that hip forward. And when you pull that hip forward, all of a sudden those joints in your low back go into gnarly flexion. And if you have a bar on your back with a certain amount of weight, 225, whatever, that's putting a lot of pressure on those discs, and they're going to want to herniate or bulge posteriorly, which pushes on all those I don't want to say sciatic nerves, but all the nerves that are in that spinal canal.
Okay.
And anatomically, there's a lot of stuff going on down there. So I know it's hard listening to me talk to try to imagine this.
But you can probably just imagine, if you're listening to this, imagine you're in your head going through that squat movement. So as you drop down, just everybody always says, the squat and the deadlift, really any major compound movement is a big mind-body connection. So it's one of the best ways people can progress through plateaus or just, form, technique, whatever you want to call it, is just to get in your head to a certain extent and just go through that motion. Yeah. So as you're listening to this, just think, okay, I'm squatting down, getting parallel. Think about how your back is moving, how your pelvic floor is stabilizing or not. How are you stationary? Are you shifting forward? Are you shifting backwards? Yeah. So everybody can walk through their own squat. The mechanics
of the squat are just huge. Yeah. People may hyperextend through their squat, which is really going to load up what's called a facet joints in your low back.
Okay.
And facet joints are little joints in your low back, and they articulate between each bone, actually all the way up and down through your spine. They're actually designed to only really put up with like 20% of a compressive load.
Oh, wow.
But the vertebral bodies and the discs are supposed to take that other 80%. A lot of people, if they just hyperextend, their core turns off
Yeah.
And they're putting all of that compressive load on those, what are called facet joints in the back, and that leads to pain. So there's all sorts of mechanics. Maybe we'll do that, just like
a whole separate
squat, like
you definitely could.
podcast where I can bring my like biomechanical doctor's approach to it, and you could maybe do more of the fitness like
application.
Approach to it.
Yeah, sure.
So I would assess you. I would determine, okay, X, Y, and Z are tight and overactive, and A, B, and C are weak. Typically, when you have a hip flexor that is tight, it's going to inhibit the muscle that acts opposite of it, which are your glutes.
Yeah.
So this is called reciprocal inhibition.
Okay.
You look it up.
Explain that.
It's basically like this. Imagine doing a bicep curl. You're activating this bicep muscle over and over and over again. And what happens is that if we're not doing anything to actively engage the triceps, because the triceps do the opposite action, right?
Yeah.
They extend the elbow and the biceps flex the elbow.
Right.
If you're only in there doing bicep curls all the time and that bicep muscle is getting more and more active and more tight, and it's working and working and working, then what has to happen is this muscle, the tricep muscle, the one that acts opposite, has to actually turn off, because if it also cranked up its muscular activity up and up and up and up, then these two muscles would be so tight you wouldn't be able to move your elbow.
It would just be like two opposing forces always pulling it.
So what happens is certain muscles get tight and they turn off the opposite muscle.
So are you saying that, maybe my anterior issue is really caused by a posterior problem, or
totally.
One expresses itself in the opposite form?
So really commonly hip flexors are going to be tight in most people because we sit all day.
Hip flexors are the top part
of your leg. Hip flexors are
the top, your quadriceps, basically, kind of where it connects into your hip.
A little bit. So your hip flexor is this big, huge, strong muscle. It attaches on the lateral aspect of your low back. It actually attaches on your lumbar spine.
Oh, wow, okay.
And it actually attaches inside that, what did we trademark earlier? Pelvic cage.
Pelvic cage. Not to be confused with Nick Cage.
No, he's quite the character. You should have him on the podcast.
I would. Nick Cage talks pelvic cage.
I love it.
Cage match.
I love it. Typically when we sit all day long, we sit, in the car to get to work. We usually sit in a chair at work. We sit in the car to get home. Maybe we work out for an hour.
Sure.
We go home. We sit at the dinner table. Hopefully, you guys are all sitting at the dinner table with your family.
Yeah.
Then what do we do to chill out? Sit on the couch.
You sit again. You watch a couch.
Right.
You don't watch a couch. Unless you have a really entertaining couch. You watch TV on the couch.
Let's all imagine that for a second. Chase sitting in his living room watching his couch. I like it.
I like my couch, actually. I just wait for it to do tricks.
So where our hips are always flexed at this 90 degrees.
Right.
Our bodies are amazing things. If our bodies are always in a certain environment, they will just be like, oh, okay, I'm going to adapt to this environment.
This is the norm.
So if my hip flexor, and my hip is at 90 degrees, and my hip flexor, that shortens your hip flexor, that your body's going to adapt to it and just make your hip flexor shorter and tighter. So that's going to cause all sorts of issues where when you go to stand up, and you should have good hip extension, right? But that hip flexor is super tight.
Yeah.
It's going to pull on that low back, and you're like, oh, my low back is killing me.
That's where we see a lot of people, constantly in that hunched over fashion. Their hips are always just tight, so therefore they never have that full upright proper posture.
Or you get the upright posture, but you have to jam those low back joints up to get straight up.
You have to force it more than it should.
Yeah.
Okay.
So if you're listening, and hopefully you're still listening, they're like 25 minutes into listening talk, and that's hard to do.
I'm just waiting for this moment for this to be over.
Most of your listeners have clicked off by this point, and
makes
I
sense.
apologize. Dr. J. Bryant podcast, the end of
First
EverForward.
First and only interview.
All right, so do this, okay? If you can stand up, I want you to grab basically a big chunk of your pants, kind of like right where your pockets are, right in your hips.
First, if you're not wearing pants, put on pants.
Yeah.
Yeah. Step one, put on pants.
If not, just grab this sort of like nice, delicious meat I think this is called like the scrapple of the human body. Just right on the front of your hips. And then what you're going to do is I want you to stand up and basically try to extend all the way up. Okay. And you will feel that sort of tension build and build and build as you get up. But what happens is this is really tight and people can't stand all the way up because the hip flexors are tight. So what the low back does is this. Could you guys all see that, what I did right there?
You can't see what he's doing. And so basically, scrunching up of the pants keeps you really tight and you can't fully extend and get that upright posture. So what he did was, he had that nice little, well, not nice, but a pretty big bow in your low back. So that stays concave, and the rest of your upper body has to kind of overcompensate. And so from the top up, it looks fairly good. Yeah. But when you look at the whole profile, it's actually all out of whack.
Yeah. So, typically with my patients, I will see tight hip flexors, tight quads, weak glutes, weak core. Yeah.
And that would all contribute kind of
all contribute to a lot of sitting. And so what I would do is I would address the tight tissues and the lack of range of motion that we're having with my hands. Okay. My thumbs are in there.
And I can personally attest to many treatments of this deep tissue work. It is not enjoyable during. You really just go into your own version of 40-year-old virgin, just yell out profanities like Kelly Clarkson.
You go into your pain cage.
You go into your pain cage.
I tell a lot of people, I warn them beforehand, say, hey, have you ever, someone who's been treated by Airrosti, did they tell you
Did they give you a heads up?
And if not, I'm like, it's not rainbows and lollipops. Yeah.
Do you hand out light sticks?
I have those tongue depressors, so yeah.
So it's definitely, imagine like a very, very, very intense deep tissue massage, but focalized on one particular muscle, one particular joint, tendon for extended periods of time. Yeah. And why do you do that? What does that do that's maybe different from what I can do with like foam rolling or lacrosse?
I tell a lot of people, can you inflict that much discomfort on yourself?
I probably could, but I don't want to.
I've tried.
When it gets to that threshold, I'm going to stop.
I've tried to treat myself before. It doesn't go well. So why I'm digging so deep into the tissue is that, like I said earlier, my manual therapy is very much geared towards the fascial component. So
for those of you who don't know, fascia
is a dense connective tissue that is in our entire body, from your big toe all the way up to your head. It's everywhere. It is kind of like the glue that holds everything up, right? What do they say all the time? We're 60% water.
Yeah, at
so
least.
You can imagine if I'm 60% water, shouldn't I have like cartoonishly big legs because all the water is just down my legs,
hang out.
But that fascia kind of holds everything up.
I always explain fascia to people who ask about it, patients, clients of mine. Yeah. Think of, when you get like a sausage or a bratwurst, you have that casing, and it's literally that. It's that casing around your entire musculoskeletal system that just keeps everything together, and that you don't really always see it or feel it, but it's there and has a lot of contributing properties.
That would be an example. There are superficial layers that are just right underneath the skin. Yeah. So you'll see a lot of providers and even just athletes that are buying like tools to like scrape.
Yeah, I've seen that.
And that treats more of that superficial layer of tissue underneath, which sometimes you can get away with, and that's all you need. Yeah. But my manual therapy is really treating that superficial layer, as well as you have super deep layers of fascia that are around the joints and around the nerves and in between each little tiny muscle fiber and in between the different muscles. Yeah. And what happens is as you have faulty movement patterns, or the cases, you can injure that fascial component, the fascial component of our musculoskeletal
the whole system.
Yeah. Whereas like muscle tissue, we all know that if you lift hard in a gym, you're sore for a few days. Yeah. And then you feel good afterwards.
The DOMS, that delayed onset muscle soreness.
You're so smart. Sometimes
you just send knowledge bombs. That's like exercise science 101.
By the way,
I think the 1-year-old squat knows that.
Chase and I both got the same undergrad from the same school, had some of the same teachers. I graduated before him because I'm better than him, so that makes sense.
And you're just like stupid old.
Yeah. Yeah. Well, aren't you? You're like 38 or 39, right?
Actually, I have my 50th coming up soon, yeah.
I will say for all you listeners, Chase, and I hate to say this in front of him, is actually very incredibly smart. He will bring up stuff about the Krebs cycle where I'm like, dude, I totally forgot about that.
Shout out to Dr. Evans at VCU if you're listening.
If he's listening, I want to call. I want you, me, and Dr. Evans on the call.
He made an impression. Him and his stupid Krebs cycle are forever.
Was he still teaching the exercise phys class when you went through?
He's the only one.
That was the hardest class in that degree.
I'm not gonna lie. Usually, studying and learning has always kind of come. I don't want to say easy, but like I never have really had to devote a lot of extra time and attention. Yeah. If I'm there and I'm present and I'm learning in like the seminar, it usually clicks. That class is the only one in my undergraduate or graduate program that I actually had to like, okay, I need to take all the notes, go home, study, review everything. It was no joke, and it really paid off for me now.
So why I treat the fascia instead of the muscle tissue, right? I may treat your hip flexor or your quads or your glutes, but what I'm really treating is the fascia that is around and in those muscles. Mm-hmm. Because if we work out real hard and we create little tiny tears in our muscle tissue, muscle tissue is typically very pliable and has great blood supply. So that's why you're sore for a few days. Your body's able to repair that little injury very easily. Yeah. The fascia doesn't have great blood supply, and it's very kind of stiff, and that's for a reason. Mm-hmm. But because of those two components, our body has a hard time repairing that on its own.
So you have to draw special extra attention to the fascia. Is that what kind of the stimulation does?
That's what the manual therapy is for, Okay. And the manual therapy, like we talked about earlier, is just a lot of just voodoo hocus pocus magic. But no, seriously.
He's got a huge pump of snake oil. He just rubs on the muscle.
I actually have rocks that I charge in the moonlight. And then when you come in, I don't even touch you with them. I just hover it around you.
If you come in on a full moon, he charges double.
So the reason that I get into the fascia with my hands is that fascia, imagine it like this. This is the kind of the best way to think of it. Imagine when you open up an old can of paint. Okay. And the paint is kind of separated a little bit. It's like congealed. It's like it's not like moving very well. Almost, yeah. And then you take that little painter's wooden stick, you put it in the paint, stir it up to get it back to its sort of normal state and fluidity. Yeah. That's what my thumbs are essentially doing in that tissue is what that little wooden stick does, stirred in there. But to get more like science-y about it is that when you start to introduce a mechanical stimulus into fascia that is sticky and not moving very well, like you'll hear me talk a lot about like gliding surfaces, and that's that muscle's ability to kind of glide over each other.
Yeah, nice actin and myosin cross paths and dropping knowledge, son.
I hate dropping when you knowledge say stuff like that. So that's what my thumb is doing, is trying to find those areas of tissue that are sticky, that aren't moving very well, and my thumb will get into them and essentially break up baby adhesions that are building up between those layers, loosen that tissue up, and all of a sudden that range of motion comes back in that shoulder. And then I take you into the rehab room. Let's go own this new range of motion that you have.
To immediately apply new
and that's what the evidence-based research says. Okay. You've got to have manual therapy followed by physical therapy to rehab an injury. And it's basically like you get in there and you break up tissue. You break up that tissue. Our body has cells called fibroblasts. Yep. Their job is to just basically lay down new tissue. So it's like, okay, I've gotten in there and broken that tissue up. Those fibroblasts are going to do what they do and just lay down new tissue. Our bodies are like amazing things.
And this is what happens after your manual treatment.
And so what I do is after the manual therapy, I immediately put a load on those tissues in how I want them to be loading that tissue up properly. And you're almost, it's almost like directing those fibroblasts how to lay down, in what direction are you laying down that new tissue. Because a lot of people say like, I go to a massage therapist and I feel really good for a while, and this kind of comes back and I got to go.
Yeah, then what do we do? We go back to the same movement.
Yeah, and the problem is that that manual therapist is in there digging up those tissues, but then you're not getting any sort of physical therapy or any specific loads being put on that tissue. Okay. So the fibroblasts are just laying down new tissues wherever they want. It's still disorganized, so it's not really truly resolving the issue. I think that massage therapy is great as like a routine. Like you go to a dental hygienist to get your teeth cleaned.
Right.
I am like the dentist who steps in when there's a cavity.
Okay.
So I'm going to take care of the injury. I'm going to give you rehab that's specific to the injury.
Okay.
But then if you want to go to a massage therapist, like awesome, do it.
Yeah.
You know, do kind of a routine thing, like have them get in there and floss those tissues. That's what you're talking about, like foam rolling a lacrosse ball.
Right, yeah.
That is kind of like my thumbs to a lesser degree, but it's like floss for our muscles. So you're trying to floss those tissues to keep them nice and healthy. The problem with sports medicine nowadays is that what do? We wait until we have an injury to then get treated. So we are reactive when people should be proactive, right?
So how can I be proactive? So I don't want to have continued back pain, or I want to avoid it and continue to progress either in the gym or just in daily living. So how do I do that? How do I stay proactive for low back pain?
Right. So what I'd recommend is go purchase like a really just simple foam roller.
Okay.
And like a lacrosse ball is what I like. It's a cheap version of. There are like mobility tools out there that are like balls, and they can cost upwards of $30-$40.
They get pricey.
Yeah, and honestly, you could get away with like a lacrosse ball for a few bucks at your local sporting goods store.
An actual lacrosse ball.
Lacrosse ball, like probably a softball you can get away with. So cheaper versions of stuff that you can do at home.
And if that's too intense for you, I know people actually start off with a tennis ball.
Yeah.
And then kind of migrate into the lacrosse ball. You want something really just dense and focal.
Yeah. And I think that, like the more that you can handle, I think the more you get out of that time spent down there. Like when you're mobilizing tissues, so those are some of the tools that you can buy to do it, right? Yeah. When you're mobilizing the tissues, don't be afraid of finding some really uncomfortable spots.
Okay.
It's okay to find an uncomfortable spot.
Yeah.
You want to try to work that tissue out there.
Okay. When should I do this? So is this like a
honestly, I would say in a perfect world, every single day, we're all spending 10, 15 minutes a day at least, doing some sort of what I call prehab.
Okay.
That's going to include some sort of mobility, including a foam roller or lacrosse ball, and maybe some stability exercises, things like that. And then it depends on the therapist that you talk to. My opinion is I would prefer to do it pre-workout.
Mobility, do pre-workout,
yes,
like foam roll.
Because I would rather get into those tissues and try to break up any adhesions that I may have in there. Yeah. And then go put a stressor on those tissues, right?
So it's just like what you're talking about with the treatment and then going through the therapy afterwards. So not only do you draw attention and blood supply to that area, but then you're immediately introducing proper movement patterns so that the body just learns, hey, this is what's right, and not go back into the same repetitive downward spiral.
It's hard to, and you really need to find someone who's going to do a movement screen and see where your faulty movement patterns are. But there's an app called Coach's Eye. Okay. And I think it's like $5. But you can basically videotape yourself, put it into slow-mo, like draw lines on it. You can videotape yourself from the side, from the front, from the back when you're doing a squat or a deadlift. And that may cue you into like, oh, that's weird how I'm doing this when I do this, and try to correct it. Like,
so I can download the app. I can get a video. But kind of going back to what I was saying about that mind-body connection. So say if you're a listener and you're a lifter, if you work out, in any way, shape, or form, what are some ways? How could I go through kind of like a self-talk, self-assessment, and like, hey, I'm just going to throw the bar on my back, and I want to go from start to finish. What are some ways that I need to walk through to really just assess, hey, am I doing this correctly? Am I moving correctly? Am I hurting in a particular area? And then how can I like auto-regulate, auto-correct that? Or is that even really possible?
You can do it to an extent, for sure. you know, take for instance the back squat, 'cause that's what we've been talking about. You put the bar. A big thing with me is what I call like midline stabilization, core stabilization, right? Essentially, a back squat, your low back should be in a good neutral position. You shouldn't feel any movement through that squat up and down.
In the low back?
Yeah.
Okay.
Your movements should be coming from your hips, your ankles. You know, your knees are obviously going to flex as you go through it.
Right.
And so try to just take a mental note, like just, you know, try to feel when your low back starts to tuck underneath you, or feel if you're supposed to be pretty upright in your squat, feel if you're really leaning forward. Like if you feel yourself really leaning forward, then your hip flexors are probably tight.
Unless, of course, you might be doing like a low bar squat where typically people are going to be leaning forward a little bit more.
I'm not as familiar with a low back squat. I've never messed with it. So, but
personally,
you and I have talked about it.
I'm a high bar squatter.
Yeah. So really you can try to either videotape yourself during a squat. I think that would almost be the easiest, is just videotape yourself, then go back and watch it.
So I'm going to think while I'm going through the movement, do I have any back movement? So my back should be staying stable the whole way down, the whole way up.
I would almost approach the bar with my core active.
Okay.
A lot of people like to get under the bar, get back in their spot, and then they go through everything. I would almost say engage this core.
Okay.
And when I tell my patients to engage the core, it is I want you to think about pulling your rib cage down to your belt buckle and your belt buckle up to your rib cage, right? Or if you put a thumb on your sternum and a thumb
dead center of your chest.
Right in the middle of the chest, and you put your other hand, your thumb is on like your belt buckle.
Okay.
And what you'll see is people will basically keep this so that your palms are parallel with each other.
Okay.
That's the best way to voice it, right?
Yeah.
Someone who's hyperextended is going to feel like this when they do it, right? Their hands are going to open up.
Arching their back.
Right? Or if they're too flexed forward, their hands are going to come close together. What I really want is that core right about here where our palms are just parallel with each other up and down to the floor.
So basically you're saying the distance between your sternum and your waistline should maintain the same.
Yeah, I mean, that'd probably be a good way. So I'd really kind of like engage that core, get under the bar. I'm going to try to keep my core as tight as possible the entire movement. Try not to feel my low back either extending or flexing as I go down through my squat. So what I do is when I'm under a bar, I will keep my core super, super tight. I will drop down as far as I can until I think that I'm feeling my hips start to tuck under me.
Okay.
And then I'll stop right there. I won't go any farther than that because I don't want to put any undue stress on that lumbar spine. Yeah. So that's what my mobility allows me to do, wherever that is. And mine is not exactly parallel. Like I can get almost to parallel with that good neutral spine because I have my own mobility issues. My hips will start to tuck right before I hit parallel. So I'm not hitting parallel every time, but I would rather train in a good movement pattern than train in a bad movement pattern because that's what's going to lead to injuries. You're talking like disc herniations, disc bulges, facet issues, SI joint issues.
Before we even get to that point, what are some mental cues, some physical cues that we should be aware of? Like, hey, I'm having muscle soreness, or it's taking a lot longer to go away, or something just feels like sore in a different way. What are some things that we as active people, as daily humans, should be aware of to help prevent it from getting worse, to get to that point of injury?
Yeah. Usually, if you start having I'm not overly concerned about stiffness. You're like, yeah, my back's a little stiff, but it's not that bad. It goes away, maybe comes back, it's a little stiff again. That may be a little indicator that you've got something going on. If you're having actual pain, either during or more so after, because a lot of people will have a heavy back squat day or deadlift day, and they'll feel fine that day, and then they'll wake up the next morning like, dude, I can't even move.
Been there.
Yeah, so that's a big red flag. Something's going on.
Okay.
You need to look for some professional help to assess you, see what's going on, and see what you need to do to.
And you guys are not like nationwide, but you're across a lot of locations.
Yeah, so our company is based out of Texas, Airrosti Rehab Centers. We're based out of Texas. We're on staff with the Cowboys. We're on staff with the University of Texas. I forgot you don't do sports.
I don't do sports, no.
So we're in Texas. We're in Chicago. We're in Seattle. We're in Ohio. And we're out here in Virginia. We're kind of spread out across the state a little bit. Yeah. A lot of those locations are going to be in Texas.
I'm just going to say, if you're in Texas in general, go to their website, airrosti.com. I'll put all the information in the show notes here. But they have a lot of locations in Texas. So if you're there, if you're an athlete, if you're just someone who's just sore for a long period of time, or just, even when you're going for an assessment and just, get some of that prehab, that proactive care so that you learn proper movement techniques, they got you covered.
Put a link up with my provider page because I want your listeners to see this face, my moneymaker that goes along with this silky smooth voice that they've been listening to.
I wouldn't go that far.
It's pretty far. Like, people call me Dr. J.
Nobody calls you that.
And it's because I play above the rim.
Stop that.
I'm based out of Virginia, here in like Tyson's Corner, I would call it.
Yeah, Northern Virginia.
We've got providers all over Virginia, Richmond, Charlottesville, and then all over Texas.
Yeah.
If you're not around us, reach out to someone, me, if you want, and I will try to ask, because usually we'll have people that are moving to different locations, and we'll ask like, hey, does anybody know a good person in Pittsburgh?
Sure.
And usually there's someone in our company that knows a guy, a PT or a chiro that treats similarly, and hopefully can get close.
Hook you up with something.
Yeah.
So all in all, low back pain is something doesn't have to necessarily be caused by the gym. It's,
not necessarily.
A lot of us have sedentary lives. Even in the industry that you and I are in, we're around a lot of active people and we're health promoters.
Yeah.
And so, but you know what? Our 9 to 5 is at a desk, seated. Seated.
Sitting.
Samsonite.
That's way off.
So really, it's, I think a big takeaway here is being aware of what you're doing, what you're not doing. So if you're going to be in the gym and trying to be more active, it's great. And probably even more important to have that prehab, that proactive treatment.
Absolutely.
But then also, if we're going to be in a sedentary environment, if we're working 9 to 5 at a desk behind a chair.
How do we combat that sedentary life?
On a chair behind a desk. There we go. Use your words, Chase.
I remember the first time I spoke.
This is my first time ever. How do we offset that? So really, you don't need to be in the gym if you're just a normal person. Our environment today is not what it used to be, and so over time, probably the biggest thing that I hear from a lot of people is low back pain problems. So, and it's not always caused by a squat.
It's super, super common. And if you think about it, any basic movements kind of is generated here and expands. It all stems from the core, right? Yeah. That core should be very functional, very strong, doing its job. Because when you kick a soccer ball, that force is being generated in your core, and it's being sent through your hips and your knees and your ankles. Same with like lifting. When you're doing a back squat, your core is tight, and that's where you're generating it from. And then your hips and ankles are dropping down, up and down into the squat. Low back pain is, I would probably say, the most common thing I see. And it can easily be corrected, and you could learn easy stuff to do to try to combat it.
Yeah.
But I see it often now, and I think it's just due to we do a lot of sitting nowadays. That is causing our hips to get super tight.
Yeah.
Our core and glutes kind of turn off, and they're not doing their job.
Yeah.
And then we go into the gym and we back squat or we deadlift. Well, guess what? Our glutes and our core aren't doing it anymore. They're not doing what they're supposed to be doing.
They're still asleep.
Now we're using our hip flexors. We're using our erectors. We're jamming those joints up. We're in a bad position. Our spine is pretty amazing. It is engineered. The way it's engineered, it should last us like 100+ years. Mm-hmm. Like we should have no spinal issues whatsoever. Because we have such faulty movement patterns, and we're basically burning that spine up, and you have kids coming in with back pain. Yeah. You're having high school athletes with low back pain. Like you're talking a kid that's 15, 18 years old with degenerative disc disease and disc herniations and like...
That shouldn't be.
Yes.
Yeah.
So there's some nasty stuff going on that's causing these spines to break down. But there's also a lot of stuff that you can do at home to to combat that and try to get that spine to last as long as possible.
Are you saying that we could treat yourself? Literally.
Yeah, you literally.
Shout out Parks and Rec.
Yeah, if my wife listens to that, she will get pissed off at me for saying. I say that all the time to bother her. I literally cannot handle this. Yes, you can treat yourself, which, I don't know, look for something like that.
We'll get you so far, and if that doesn't work, definitely check out Airrosti. They are really, really good at what they do. I've seen Dr. Bryant. I've seen several other of their providers for hip issues, low back, shoulder. Basically, anytime I go in the gym and get a little too carried away, forget my form, forget my technique, my body reminds me, come back in, they reset me. So thank you very much for explaining low back pain and teaching me how to treat yourself.
Yes. And to end it, I'm going to flip this around.
Ooh.
Now, I'm the interviewer.
My, how the turntables. Just refer to me as the captain. I'm the captain.
All right, Chase. So thanks for being on this podcast with me today. I really appreciate it. Let's pretend like all of your written knowledge that you've put out into the world, your YouTube channel, your blogs, your podcasts, are all wiped away. Gone. And you were dying.
I don't like where this is headed.
And you could tell the world 3 things. What would be the 3 things that Chase Jr. can tell everybody?
Okay. If you're ever having a bad day, get a cake pop. You cannot continue to have a bad day and eat a cake pop at the same time. I like to call them happiness on a stick.
Next time I'm on, let's talk about our cake pop story. Okay.
We have some good cake pop stories, secondly is reverse engineer your life to really help develop your goals. A lot of times people think that they are supposed to be one way, or supposed to be doing something, working out a certain way, eating a certain way, and the biggest friction point that I've come to realize is that it doesn't match up with how they want to live their life and who they are, true to their core. So know your life, know your lifestyle, and then figure out how you can best match that to what you want to be. Lastly, if you're ever at a coffee house and don't know what to get, cold brew.
A lot of coffee-related points.
This just in. Chase likes caffeine, cake pops, and work-life balance.
I like it.
Yeah. Oh, and overall, just, know yourself. The rest of it will be created for you, I think. You don't need to try to put yourself into anyone else's mold, whether it's eating habits, lifestyle, working out, financial goals, relationship goals. Just too many people spend so much of their time trying to put themselves into someone else's path, and it never works out because they're starting off comparing themselves, and they lose themselves in the way.
Don't lose yourself.
GPS, we're good. All right, everybody, that's a wrap for this week's episode of EverForward Radio. Thank you to Dr. Justin Bryant for dropping some science bombs with us here. And I like where this is headed. I think definitely with the audience here, most of my people, most of my listeners are active in some way, shape, or form. And we all get boo-boos. We all kind of forget our way and forget technique and get sore, get injured. So I definitely think that I would like to have you back for maybe some other topics.
I'd love it, man.
Yeah. All right. Thanks, everybody.